Okay, it looks like the participant numbers have slowed down quite a bit, but I'm sure we'll have others join us as we move forward. But for the sake of time, I think we can go ahead and get started today. Thank you for joining us for the Systems for Action Research and Progress webinar series. My name is Carrington Lott, and I am the Deputy Director at Systems for Action. If you're joining us maybe for the first time or are not familiar with Systems for Action, we're a national program office of the Robert Wood Johnson Foundation, and we're housed at the Colorado School of Public Health on the CU Anschutz campus in Aurora, Colorado. And one of our main activities at Systems for Action is to fund research all across the country, looking for innovative ways of aligning across the social sector, the medical sector, and the public health sectors to achieve health equity. And more recently, one of our focuses is on how teams can align across these sectors to dismantle systemic racism. So during our Research and Progress webinar series, which we usually have every 2 weeks or so, we have some of our grantees from the Systems for Action Research program come and present on their research in real time. So you get to hear from them in the beginning, middle, and end of their project. So you get to kind of follow along with them as they're learning things in their research. And today you're going to be hearing from one of our teams at CUNY, the City University of New York, and they're going to be talking about their multisectoral task sharing to improve mental health in Harlem project. And they are about 2 years in, so they're going to have maybe some preliminary findings to share with you and some important updates that have happened along the way. And I know that you're going to hear some great content from them. Can I get you to go to the next slide, Vidya, please? Thank you so much. So just setting the agenda today, we're here at the welcome right now. A couple of housekeeping items before I hand it over to the presenters. We are recording today's session, and we will share the recording as well as the PDF of the slides and any other resources that the team shares with you after today's session. And we will have time at the end of today to have a question and answer section. So if any questions come up along the way, please locate the Q&A box at the bottom of your screen and enter in your question, and we'll make sure that we save some time to discuss those and present them to the team. I think that is it for me. I'm going to go ahead and hand it over to Vidya, who can introduce the team and then tell you a little bit more about their project. But thank you so much for joining today.
All right. Thank you, Carrington. Good afternoon, everybody. Thank you so much for joining this session. I'm Shri Vidya Sharma. I go by Vidya. I'm the Senior Program Manager for Harlem Strong. So Harlem Strong is a multi-sectoral sectoral community coalition collaborative. And these are our project directors. It's the brainchild of our director, Dr. Victoria No. She's the director of the Center for Innovation in Mental Health, which is CIMH, and Dr. Malcolm Punter, who's the president and CEO of the Harlem Congregation of Community Improvement, which is HCCI, Deborah Levine, who's the director of the Harlem Health Initiative at CUNY School of Public Health, and Dr. Susan Bean, who is the Executive Medical Director of Health First Managed Care. As I mentioned, I'm the Senior Program Manager for this wonderful project. And I'm joined today by Dr. Alexandra Restrepo. Alexa is our amazing postdoctoral fellow, and she's also our research manager. I'm not going to go much into the detail of introducing ourselves. This will be sent to you as slides. So I'm just going to, for the sake of time, going to pass on. And we're also joined by wonderful Kamia Nelson, who is our housing agency partner and also partner with Harlem Strong for the last almost 2 years now. She does wonderful work, and she'll be explaining a little more about integration of Harlem Strong into Hope Community. Yeah, going forward, this project is funded by Robert Wood Johnson Foundation, the S4A, and CUNY Interdisciplinary Grant, as well as the NIH Transformative Research to address health disparities. Okay. Harlem Strong, as such, is a multi-sectoral community coalition collaborative, and we have a number of goals. Uh, the most important goal for this is to build a multi-sectoral coalition to support integrating mental health. So the way this program actually came about is around 2021, post-COVID, we did this needs assessment that showed a high level of mental health need in the community, especially in Harlem, as well as socioeconomic and inequities at alarming rates, which was 3 to 4 times more than what was pre-pandemic. The directors, which I just spoke about, who I just introduced, they came together to think of a way to address these needs. And the most important thing that came out of that meeting was to build a multi-sectoral coalition. So that is our most important goal. And then the next is to strengthen capacity for navigators. So what we do in our program is we provide short-term targeted trainings to community-based organizations who maybe are or could be healthcare focused. So in this way, we are aiming to build capacity for the system where because we have such a dearth of behavioral healthcare providers. And at the same time, we want peers to be able to, screen, identify, educate, and coordinate mental health support services until and unless they are referred to a behavioral healthcare provider. The next important thing is to integrate mental health support into, various affordable housing and public housing settings, as well as primary care and community-based settings, which are much trusted by people and are visited by people very often. Finally, it's very essential to evaluate the impact of this program. So that is our final goal, and assess the implications for future care and policies. These are our wonderful coalition partners. We definitely cannot do without any one of them. We have around 70 plus coalition partners at this point in time. As I mentioned, they are community-based organizations. We also have faith-based organizations. We have city agencies. We basically work in collaboration with each one of them in Harlem and aim to fill the gaps for and amongst each one of them. So these are some of our coalition partners who are very actively involved in the program. This is our community collaborative care model. Navigators are essentially the center of our program. And as you see, they work in, basically primary care or housing agencies. Either they work or we place them in these agencies, but they also work in collaboration with the community, with the community-based organizations and the faith-based organizations. And they refer people to when and where they are needed. So this is our care model. And as I mentioned, there are a number of sites and number of coalition agencies. The gateway sites are basically where we place our navigators, and we work very closely with them. So these two are primary housing agencies, SCCI and Hope Community. We also work with primary care agencies. Currently, we are working with Heritage Health, Acacia, and Ryan Health. And the Center for Comprehensive Health Practice, or CCHP, will also be joining us soon during our next cohort. Apart from that, we also have the coalition agencies that support the work of our navigators. But however, we also do train members in the coalition agencies. They do follow our curriculum for implementing Harlem Strong in their sites. So we have around 50 of community-based organizations. This is approximate, but it's almost always dynamic and growing. We also have faith-based organizations. We have primary health and behavioral health care organizations. So this is basically a consumer's journey to resilience and the pathway that our navigators use in order to, provide services for the client. So initially, we always start with community outreach via tabling events or via our organizations or even health fairs and community events. So navigators do screening using a PHQ-4 or wellness check, and then navigators are trained to do psychosocial assessments, and they provide client education. They then provide them with stress management and wellness skills during this process. So basically enabling the consumers to have or develop those coping skills. And where and when needed, we also refer them to the care that's needed. Moving on to the training that we provide. Basically, for building the system capacity, as we mentioned, that's one of our primary goals, to build a capacity within the system in our community. We offer trainings. The trainings are basically, they are hybrid training models. Online training is available. After every online training module, we give them webinars that are live webinars, and it's done by clinicians, followed by in-person workshops. And then we pass on to coaching, which is done every week. We have consultation to the navigators as they are trying to implement the model to clarify any questions that they may get depending on the cases. Again, navigators are, trained at gateway sites and also at the coalition sites. And finally, we aim to build a community of practice to support mental health. And in order to do this, we have learning collaboratives and we have coalition meetings, which are held quarterly. These coalition meetings, all our network of coalition is invited. And we concentrate on various topics which are generally requested by the navigators or the coalition agencies themselves. We've had coalition topics on spirituality, faith and mental health, provider benefits, and immigration health, and so on and so forth, depending on whatever was the need at that point in time. This is basically, the training curriculum for our navigators. We have around 6 modules. After every module, we have a live webinar. And then at the end of the training, after these 6 modules, we also have in-person workshops that are geared towards skill building and case examples. These are the toolkit that is available to our navigators during implementation. We have designed a Harlem Strong resource directory that is a comprehensive guide to mental health and community resources available in Harlem. This is again dynamic, so we keep updating it according to the new resources that are available and deletion of the old ones. So our navigators use this during their reference. And then they're also given a complete implementation guide, which contains all of the flowcharts, the checklists, and the forms that are needed as they are doing the assessments, which include PHQ-9s, GAT-7, and the different components while they're doing mental health task sharing. Finally, we also have the eHub, which hosts the online platform, and that is, we use Moodle, and that's a one-stop shop for, it has all the training events. It contains our training and also the events, and also gives the current news and any additional resources. Everything is uploaded into this eHub, so it's available for the navigator when and where they need. It can also be accessed via their mobile phones. And as the navigators have started their implementation, we provide them with any support that's needed for the navigator as well as the sites that are hosting them. We have implementation planning. We have weekly meetings with the coordinators or bi-weekly meetings with the coordinators after some time. We have a navigators internship program where we train our own CUNY School of Public Health interns to become navigators and thereby enhancing the workforce, behavioral health workforce. And we always aim at strengthening our referral network via coalition meetings. And we are always on the lookout for new nonprofits and organizations that will help us do this work. Community outreach is done almost every week. We visit sites 3 to 4 times. We have coalition meetings, and we also have client management tools, which I've gone through. We totally have five cohorts in this study. Ours is a NIH-funded randomized control trial. We have five cohorts. Alexa will be explaining the research component a little more in detail, but currently we are in the fourth MCC4 cohort. I'm passing this on to Alexa, Dr. Alexandra Menau, our research manager. Alexa.
Thank you, Vidya. This is a very complex intervention. Therefore, we also have more than complex comprehensive evaluation. In this evaluation, we want to assess the effectiveness of this multisectoral community coalition. And we are assessing the both outcomes in the patients and also the implementation outcomes. And for this, we have three groups that Vidya, can we move to the next slide? We have three groups to compare. We have the educational resources. We have the multisectoral collaborative care, that is all these network institutions there, in which we have a navigator that help to the consumers to navigate to a service. And finally, we have this same multi-sectoral collaborative care plus a software called Open EMR that help the institutions to follow the consumers through the treatment and through the prevention strategy. Then we are doing can we pass a last one? We have a mixed method design that have two components. The first one is a hybrid implementation effectiveness design that it consists of a cluster randomized control trial. And we are doing a special wave of this cluster randomized control trial that is called stepwise, because we are having the people not randomized to the intervention, but randomized a sequence of interventions. And in this hybrid implementation design, we are evaluating the consumers and we are assessing the effect of mental health, specifically in the page Q9 and the GAT7. And also we are assessing if they have an improvement in the contact with services. And we also have outcomes in the providers, because we are measuring the skills they have to manage these mental health problems and stress. We are assessing before and after the intervention what happens with them, and also the program barriers and facilitators. And in the second part of this method design, we have a qualitative approach. Basically, we are doing in-depth interviews and focus groups to assess the barriers, facilitators, and the satisfaction that providers and consumers has with the program. Then we have some primary and secondary outcomes in different levels. In the consumer level, we are measure the primary outcome, the page Q9 and the GAT7, and also if they reach a screen and they increment the screening of mental health programs. And as a secondary outcomes, we are assessing the quality of life, the social support, and the changes in stigma and beliefs about mental health diseases. In the provider level, as I told you, we are measure the attitudes to evidence-based practices and the skills that the providers have and how they change over time. And in the system level, we are measure as primary outcome the mental health service linkages. Like we are actually improve with these navigators the connections that the consumers has with the system, and they are navigating. And also we are measuring the facilitators and barriers of the implementation, as well as if this intervention is sustainable over time. And in the pink, we have highlight those outcomes that are related with the implementation. Therefore, because we are mixing here both implementation and the effectiveness in the individual level, this is a hybrid design type 2. Then how we randomize, like in Harlem, we have a series of services and buildings. And what we do is group these buildings and areas in cluster. And this grouping happen because the organizations in the community know better like how works the community, and we group this in clusters. Therefore, we have 20 clusters, and these 20 clusters were grouped again in sequences. And in the next slide. And then we have 5 sequences that you can see 1, 2, 3, 4, 5 in the rows. What we randomize is like the order that they will receive the intervention. Then the first sequence is the first row, that is the first 6 months they receive training. And we call transition, because in this moment they are not implemented, but they are making agreements about who is going to be task sharing navigators, like we make the training. And then at the following 6 months, period 2, we do actually, they start implementation, and they receive the implementation for 18 months. And then they pass to the other intervention, that is the MCC, the multi-collaborative group, plus technology, plus this software that we talked before, that is called Open MRI. And they also have both during 2 years. And the second sequence, they have other order of the intervention. They start just like resources and information in the first 6 months, and they follow at the second 6 months as transition. They receive the training, and then they continue with the implementation of the intervention. And then this is complex because the reality is complex also, but also we can do multi-level analysis to assess, when we have the sample, the total sample, to analyze this cluster and these sequences, and taking account there are clustering in these sequences. We are now in the 4 period. That means that we have working the MCC1, the MCC2, and MCC3 that are implementing, and we have having the MCC4 in transition. Therefore, they are now training. They are receiving the module training, the webinars, and all the coaching with the team. And we have a group that is in just the call, it's like a control group. They are receiving just resources and information. The next one. And then, like, here's a summary what data collection is going. We already have a total of 44 ENR participants and 33 MCC participants. We are a little behind, and we are doing everything for increase this engagement with the program. But it's difficult because people is a little like lost. They are hopeless. I think they are not engaging in anything because I feel like they are having bad experience before with services and other things, and there are no one to engage. Then we have to convince that we are not like the other ones. Also, what happened, I don't know if Vidya will talk, like even we have a period of transition as the previous slide, then they receive the intervention because we have in the providers changes of the personnel, and think we just keep going training and including more navigators and providers during the time. And then it's like the training is all the time happening, and that way we maintain engaged the navigators during the periods. And continue in the following. And for now, we screen a total of 524 consumers. So we screen with the page Q4, and 340 met the eligibility of criteria. The eligibility is like have between 13 to 65 years old, and work or living in these areas that we talked before. There are clusters. And they completed 162, the T0, this is like the baseline. And we follow 25 to the T6, that is a second measure 6 months after the baseline. And in general, we have participants that have a mean of age of 46 years. Mostly, like almost 70% are women. And we have like 50-50 participants that identify like Black American and another like 40% Hispanic. And we have a high level of depression. Like when we do the page Q9 and we code for 10, that is like the code point that show people that have moderate to severe symptoms, we found that 37% of the participants had high level of symptoms of depression, which is very high comparing with the general population that it goes between 16 and 20. And that is like show like in the baseline they're having like need of really these services. And the following, we also have providers. We collect providers. The providers that make the training, before do the training, they fill a survey, and they have also following surveys 6 and 12 months. We currently have engaged more than 130 providers that consent to participate in the study because they can have the training and don't want to participate in the study. And 102 completed the baseline, and then 28 completed the T6 at this moment. And in general, they are 43 years old. They identify a woman almost 70%. And again, we have like distribution 50-50, 50% of Black or Black American, 23% Hispanic. It is because we have an area that is a lot Hispanic immigrants or Hispanic speakers, and 16% born outside the country. And the following, we have analyzed a little bit about the stigma and the providers, and for them is they are more comfortable with having physical than mental diseases. Like that's a sign of there is a stigma. And 49% of the providers will not report their own mental illness because they're afraid of being rejected. That also show that the environment is still mental health problems, is a discrimination of people with mental health. Even they are providers and receive this kind of trainings. This is a baseline. We hope that after the training, things improve. And the following. And also we have like 23% of these providers have a high level in the page Q9, like the stress. And from this, 2% is severe, 7 moderate. Also measure the mileage burnout inventory. Using the 9 items inventory, we found that they have high level of emotional exhaustion, like 13%. Problems with the professional efficacy and this balance between the personal accomplished and the work they are doing. And 7% have symptoms of despersonalization or empathy with the consumers. That means that we have like high level of mental health among our own providers. And that is no surprise because this happened a lot after, before COVID. And therefore, like we are adding some stress management that are for them also, like some support. And in the webinars and group activities, we try to make the reading and wording these topics too. Next one. And we have some publications already. We have like the general protocol that you can access in the BMC Public Health the last year, and also analyze some aspects like barriers of mental health services and the needs in mental health, the substance use and alcohol use among the participants, and describing also the needs that they have in mental health. I pass again to Vidya.
Thanks, Alexa. I'll quickly go through some of our accomplishments with reference to technology, but we are just getting into our technology component, so we are in the process of implementation. The first thing, the first major success for us is basically our contract between HCCI and Health First, supporting Harlem Strong implementation using their Helping You program. HCCI can now is able to bill for their Harlem Strong services with Health First. So that is a major step towards sustainability of Harlem Strong in their organization. And we are also in the process of developing open EMR for data entry and tabulation and then analysis to enable data analysis. So that is in process, and we hope to be able to fully implement that. This will be shared with our gateway sites and organizations that are generally not able to have EMR buy a EMR. So this is going to be completely free and open for them to use. This will be hosted via our CUNY service. So these are two, major accomplishments with reference to the technology. Right. So moving on, we have Kamya Nelson. She is one of our primary, housing partners. She's the director of resident services at Hope Community. On to you, Kamya.
Hi, good afternoon, everyone. No need to reintroduce myself. So we've been partnering up with Harlem Strong for a while now. We have three navigators. As a property management company, I have found that mental health, like informing residents and helping them, especially for low income, it improves resident stability. It helps with us really understanding like what's going on with the families and just households in general. A lot of residents I found do have some level of mental health, but don't know where to go. So by partnering with Harlem Strong, it has given us the opportunity to connect folks to care. And what I like about this, it's like I had an interaction a few weeks ago. A resident came by. She's having so much going on. We did the screening with her. We're now in process of enrolling her in a program. But I was also able to connect her to one of our partners through the Harlem Strong Directory, Housing Works, because she did express that she has suffered previously from addiction, and with everything that's going on, she just felt that she needs that support. So I was able to directly contact someone from Housing Works and connect her and get her an appointment and get her set up with care. So I find that is really great because, as a property manager, you don't know, normal property managers, companies, they don't know where to go. But by partnering with Harlem Strong, you're given these resources where you can actually give to residents. And this just helps with that tenant landlord relationship, because now in a way, you're not as just, yes, I'm having all these issues, I may have arrears, but you're also able to provide me some level of assistance or in support. So I find that really beneficial working with Harlem Strong. I also see that in enhanced community well-being. What's unique about Hope Community, we have a resident service department, which we provide soft case management to residents in our buildings. So it's voluntary. It's not like supportive housing where you have to participate. This is very voluntary. So Harlem Strong has allowed us to tap into residents that we, didn't even know exists, or even didn't even realize that this service existed at Hope Community, as well as the support we can give them through working with Harlem Strong. We've been able to do have support groups like wellness groups to talk about wellness, because there is a stigma in the Harlem community about mental health. A lot of folks don't feel comfortable discussing mental health. So this was a way for us to do a way to kind of start that conversation. So how we've been able to start that conversation is we did a paint and sip. We partnered up again with Housing Works. We got this through Harlem Strong, and we partnered up with them, and we did a paint and sip. And, it was a way for us to just like talk to residents and say, so isn't this nice, enjoyable? And we're just having regular conversation. And they really were feeling good. Just sitting there painting and talking and just socializing. And we spoke about, how does this make you feel? Because part of mental health is, just understanding and checking in with yourself. Most recently, we did a wellness event at our senior building to kind of talk with the caretakers for our seniors who like home health aides or family members that come by to care for the seniors. And we did a wellness event. We did some screenings at that event. And again, we were able to have that conversation about wellness, mental health, and self-care. And really what was important, what I found, my takeaway from that experience was we were able to kind of talk with the elders, even though because they're 65 and up, they're not a part of the study, but we were able to talk with them to say, if you know anyone in your family that is experiencing mental health or not feeling great about themselves, you could have them reach out to our navigator, who they already have a rapport with. They already trust the navigator because they know her. And they were like, oh yeah, I'll tell my friends to come and talk to her, and maybe we can get enrolled into the program and have that conversation about mental health and self-care. We are continuing to work with Harlem Strong, Vidya, very supportive, Francesca, just coming in and continue to support my staff and myself with, just skills on how to have that conversation with residents, thinking about different groups we can do to bring people in, because the goal is to kind of kind of break the glass ceiling in a way and have that conversation about mental health, about wellness, about taking care of yourself, understanding about how you feel and why you feel this way, and knowing that there are places for you to talk to someone, and we can help you get to those places. So I find that this study has been very beneficial. It's also beneficial with our property managers who do interact with residents, because now, if they see something, they're pointing it in my direction. And then I have one of my staff go ahead and, engage with that person, because being in low income housing, there are a lot of barriers our residents face. And, sometimes they do think that they have nowhere to turn. So I'm really happy that we are able to offer them this. My vision is to see us do more community events, to just get more people integrated in the community, and to really start having that conversation about mental health and about taking care of yourself, and just really just breaking that stigma that's really here in the community.
Wonderful. Thank you, Kamia. Kamia is one of our wonderful and very passionate partners. She's always there for her community. She's always there for her people, apart from her job, which is primarily, the director of the housing services there, but she is also very interested in the well-being of the people in her community, which is very commendable. So thank you, Kamia. I think I'll share my screen again so we can go to the Carrington. Do you want to take it from here?
Sure. Thank you so much for presenting on some of the updates and things that your team has been busy working on over the past year, I think, since you presented. And Kamia, thank you so much for joining and providing some commentary on the importance of this work and how it's impacting the community that you're working with. We are now at the Q&A portion of the webinar. So if any questions came up along the way, please put them in the Q&A box. I haven't seen any come in yet. That doesn't mean you don't have them. I guess I'm saying that because if you do have a question, any question, big or small, we will likely get to it. So please put your questions in. And I guess I'll start off with a question about just what next steps are in your project and what you're hoping happens and how you're continuing to engage the community. And if you just kind of want to talk about the future of the project a little bit.
I'll go first. One of the main things we are right now looking at is implementation, because we have sort of established, we are almost done with the training part. We just have one more cohort to be trained, and we do have a lot of wonderful navigators right now. So what we are looking at is essentially supporting our navigators. So we have some new postdoctoral fellows who are clinicians, who are raring to go into the community along with our navigators. So we'll be placing them in the housing sites and also in the primary care agencies as well as the coalition sites. So these clinicians are primarily going to help people understand how to integrate Harlem Strong into their routine work. Because as Kamya was mentioning and also as Alexa was mentioning, one of the major issues we've had is a lot of staff turnover and staff burnout. Since people have too many, they're wearing multiple caps already. They do not know how to also implement Harlem Strong into their routine work, even though they really want to do. So essentially, our aim is to tailor Harlem Strong for different communities and community-based organizations, and give it to them in a platter so they understand how to, regularly talk to them. If it's a vaccine champion, if it's somebody doing vaccine work, we want to know how they would, understand if a client that's coming to them can use Harlem Strong services. So giving them a script accordingly. Right now we are working with some of our coalition agencies, it's called Grant Associates, which are basically providing career services for vulnerable communities. So we are going in there and talking to those communities and training their navigators about whenever a person comes to you for career, they're, amongst the vulnerable population, they're already so stressed. So you want to integrate, Harlem Strong, just general wellness checks and help them out. So basically that's our, next direction, and also the sustainability.
Wonderful. Thank you so much. And like I mentioned at the beginning of today, this is an ongoing series. So this team will come and present in about another year on what's happened, and they can provide some of those updates. So it looks like we do have some questions coming in. The first question I'm going to ask is from Henry Chung. And that question is, are providers the navigators, and how do you support those who have clinical scores for depression and anxiety?
Alexa, do you want to go, or?
You are asking about the providers, how we support them, or the consumers? It wasn't clear for me, the question. Can you hear me?
Yes.
Because okay, for the providers, there is a couple, some of the providers already have mental health problems, and what we are doing is in the same intervention and the training they are receiving. We are support them because we saw also high levels of burnout. And then also the navigators have provided service to those patients that have higher scores of PHQ-9 and GAD-7. However, when we detect that somebody have symptoms of suicide ideation, we have a procedure to follow and be secure about these consumers. Where somebody that answered in the PHQ-9, the question of suicide ideation is a question 9. And we have the procedure that somebody in the team, specifically one of the clinical postdocs, make a call and make a risk assessment at that person. and they refer, like if they really, really see that the patient is at risk, commit suicide or also violence with others, they call a 988, that is a number here in New York for mental health emergencies. And 988 provide the services that they need in emergency services. They move to a hospital and provide the service they need, but this is an emergency. And also, if no, it's just symptoms, but already is not a clear plan and or reason to commit suicide, what we do is like we have navigators already, and we have these health providers, for instance, Ryan Health or other health providers. And we refer these participants who are our key navigators, and they help them to go over these symptoms and look for like how plays in her system according with the insurance and everything that almost everybody has based on the same community. Then that is the system we had. And in that way, we're trying to reduce the risk of mental health problems, serious mental health problems. Also, we have a criteria of nobody when we do a screening and we detect that somebody has serious mental health problems, we don't include because this is a prevention strategy, secondary prevention. That means that we have people that have risk factors and some symptoms, but they are not like established mental health problem. Those participants also are referred to mental health services because like if it's not can work, but they need something else. They need more than just a prevention program. What we want is the people that is at risk, that have the environment, they have multiple basic needs that they don't fit these needs. We provide that in order to reduce the risk factors and try to reduce at the end people that have serious mental health problems over time. And we know already that if we prevent this, we prevent serious depression and anxiety, this kind of chronic disease that can affect the population over the years. Then that's the strategy. I don't know if I was clear, Vidya.
Absolutely. I think you addressed most of it. The first question was, are providers the navigators? Yes. Anyone who provides service is considered a provider for this. Navigators are the ones that are being trained to become providers. So navigators are providers. Apart from that, anyone who's being trained in the community-based organizations or the coalition sites are also providers. So the numbers you see are for both. So all of them receive trainings to do the mental health task sharing. And I think Alexa just mentioned various ways of how we support people with clinical scores for depression or anxiety. But I must give the disclaimer that this program is the trainings that are provided to the providers are for people with low and intermediate moderate stress and anxiety. Anyone that scores higher than 9 or 10, we refer them to behavioral health providers that are there in our coalition and that are close to their residence location. You know, as long as they are comfortable. And also, as we are providing services, if we see that their scores are getting higher and they are not getting benefited, they still are referred to behavioral health care as needed. So this is sort of meant to be a supplement for people with higher, depression or anxiety because providers are not trained to give that level of, care.
Thank you both for addressing that. It was very helpful. I think I'm going to skip a question here because you were just speaking about the navigators and training the navigators, but someone had a question about what the recruitment looks like for the navigators. So I'm wondering if you could touch on that a little bit.
Sure. So the recruitment for navigators, we are open to people from various community-based organizations in and around Harlem. Whoever gets consumers from Harlem, they are eligible. So we generally meet them during various events, promotion, awareness, and we are based out of the CUNY School of Public Health, which also has a lot of community engagement in the Harlem community as such. We are housed out of Harlem. So anyone from those organizations are eligible. All that we need is their name, role and their interest in the program. And then we talk to them and enroll them. They are given access to Moodle, and they are invited to all the training. So it's a very simple recruitment process for the navigators. We want to make sure that they attend the entire program if they are interested in providing the navigation as such. But if they're just interested in the knowledge part of it, to be a supporter, they are welcome to.
Great. Thank you so much, Vidya. The next question I'm going to ask, I feel like Alexa, you might have touched on this a little bit, and I think I'm going to rephrase the question with how I understand it. So Douglas, if I'm misrepresenting what your question is, please type in and let me know. But the question is, besides housing and mental health challenges, are you hearing from the community and residents that they are experiencing other impacts and like barriers and challenges to accessing other services that impact their social determinants of health?
I think Kamya will be a great person to answer that.
Yes. So we found out a lot of our residents, it's financial. And we have folks that dealing with food insecurity. So we have been working with with partners like Harvest Home to provide some type of fresh produce and food for them, referring them to different pantries in the area that offer food services. For financial literacy, we actually host financial literacy workshops because that's really important, so folks can learn how to manage their money better, as well as ways to get access to additional income for their household. So we do encourage residents, if they're able to work, we're helping them locate a job placement. If some residents who might have a disability, there's a program called DREE here in New York City where their rent can be frozen and stay the same rate for a period of time as long as they meet the qualifications every month. And we've also helped families and single adults also apply for emergency grants to help with any Con Edison bills or rental arrears. So, I mean, we do run into those things of, additional support besides mental health that folks may need.
That is extremely helpful. And I'm sure as a trusted partner in the community, you have lots of other connections as well. So it sounds like it's very helpful. Thank you.
And I want to add that there is this definition of resilience that is for a professor in Canada. They said that resilience is this capacity that have the individuals to navigate through services and resources. That means there are personal characteristics, but also you need resources in the community. What happened here is that we have a lot of resources, but we don't have this navigation. They don't know how to navigate. When that do navigators has helped them to this navigation. That help them to have these abilities that they don't have, like self-efficacy, self-determination, to build that resilience they need access to these resources. I think that connect our thinking about resilience and this structure with where we are doing the communities. And then for this, it's very complex also. We need this complex evaluation. That's my take-home messages.
Thank you, Alexa. I'm going to move on. I know we have 5 minutes and we have a couple of more questions to get to. So I'm going to maybe get through these quickly. But the next question is, do you have multilingual support for people with LEP? I see Camilla nodding her head. I'm not sure who wants to address this one.
As of now, the only other language that we have Harlem Strong is Spanish. So we have been having a lot of issues with just retention of navigators. So we've not been able to tap into the different potentials of navigators. So they've been trained, but there's a lot of transitions. So even with the reference to Spanish support, it's been pretty difficult to actually hire navigators with Spanish capabilities or other language capabilities and retain them. So currently, we do not have support for people with different capabilities or different language support, unfortunately, but that should be something we should have in the future. Um, I think the NIH funding, do you want me to go through that? Uh, NIH funding, we've not been affected until now. Hopefully, we will not be. But we definitely see a lot of issues with people trusting us with their information. Like one of the things, if I had to give an example, for people to be billed under Health First, the partnership I was talking about, we do need some data from them. We need to know if they have insurance. We need to know their date of birth. So SACI can bill them. But something as simple as that can be very sensitive for people to give you. And in the current political climate, people have been very hesitant to give anything that is really, real. Yeah, that has been an issue.
Yeah, yeah, and we can see in the surveys that we start asking about symptoms that are fine, but when we ask the personal information, people stop doing the survey. People is, like, I will say, afraid, and it's understandable. But that means we need to engage more the community.
Yeah, I completely agree. I think we're hearing that from a lot of folks that we're working with that are doing many different projects, and there's just a lot of mistrust and uncertainty right now. So, okay, I know we've got 2 minutes left. I'm going to ask one, I think, question that maybe might have a more brief answer, and then the two we don't get to, I'm going to ask the panelists to answer those, and we can include the answers in our follow-up emails, if that's okay with you guys. And then we have a couple of announcements, and I'll close us out just to be mindful of time. But the last question from Julie Ressalom, apologies if I missed this, but are the navigators completely grant funded, or is there any reimbursement from CMS?
They're completely grant funded. And the funding is quite, when I say we are funded, it's the amount of money we are giving them is quite minimal. It's more like a stipend. It's a navigator stipend. But these people are generally being paid by the housing agencies where they are working. This is in addition to their income. Again, our interns, they are all students. So this is an addition to their situation, but it's completely from the grant.
Thank you so much. Okay, in the last minute that we have, I'm going to close us out. Just again, thank you for coming and presenting on your research today. And thank you for all of our attendees for coming and listening and engaging and asking such wonderful questions. This is an ongoing webinar series, and I see that my colleague has posted a link to register for the next webinar on April 30th in the chat. We will also include this in our email follow-up. And we hope to see you there. But thank you so much for joining today, and I hope you have a wonderful rest of your Wednesday.